Good afternoon and welcome to this virtual program of the Commonwealth Club. I'm Mark Zitter, chair of the Zedema Project, of which today's guest is a member. I'm a member myself of the Commonwealth Club Board of Governors and of course your moderator for today's program. The Commonwealth Club has suspended all of its in-person programming due to the pandemic, but is hosting a series of virtual events like this one. We encourage you to learn more about our upcoming programs by visiting our website at commonwealthclub.org. We're grateful for the generous support of our members and donors and hope you will consider making a donation yourself. You can make the donation online at our website or text donate to 415-329-4231. We'll post that number a couple more times during the program. And we also encourage you to like, subscribe, and share videos like this one with your friends and family. The Commonwealth Club is the nation's largest and oldest public affairs forum. We've got lots of great programs for you and appreciate your support. During the program today, you are welcome to ask questions via the chat box. Submit them and I'll get to as many of them as I can. Now it's my pleasure to welcome back to the Commonwealth Club today's special guest, Dr. Ezekiel Emanuel, author of the new book, Which Country Has the World's Best Healthcare? Dr. Emanuel is the Vice Provost of Global Initiatives and Chair of the Department of Medical Ethics at Ethics and Health Policy at the University of Pennsylvania. He's also a special advisor to the Director General of the World Health Organization and a senior fellow at the Center for American Progress. Dr. Emanuel was the founding chair of the Department of Bioethics at the National Institutes of Health. With all that said, he may be best known for his role as special advisor for health policy in the Obama administration, where he helped craft the Affordable Care Act, and also for his role in defending it ever since. I think I could spend the rest of our session just talking about his accomplishments, but instead, let's get right to the program. So Ezekiel Emanuel, welcome back to the Commonwealth Club.
It's great to be here in this different format.
It is a different format. I think that I've interviewed you 2 or 3 times in the past, each at a different location, but I think most recently at our brand new building, which we're hoping to get back to soon.
Yes,
so
it's a beautiful building.
It is beautiful, and we hope to see it again soon. But right now, I think we can do pretty well this way, especially because you've got a lot of material in this new book, Which Country Has the World's Best Healthcare? And of course, by asking that question as a title, I have to ask you that question. Were you able to identify a best healthcare system in the world? And if so, we sure want to know what it is.
Well, we did not identify a best healthcare system. And we also, as we conclude in this book, there's no system which gets a grade. I'm a professor, and so we're used to grading things on the ABC level. What we ended up doing is identifying 22 different metrics that we think are important to people. Some of them important to policy wonks like you and me. Some of them important to the lay public, like choice of doctor, low drug prices, no paying at the point of care. And a lot of these are more qualitative than quantitative. And so we evaluated countries on the basis of these 22. Let me say that we did end up with a group of 4 at the top. And a lot of it, which ones you prefer, depend upon your preference for these metrics. So if it's really important to you not to have any money at the point of care, you think of Britain and Canada, Germany. If you really, really want more or less unlimited choice of doctor and hospital, you think of Germany, Switzerland, France. And so it really does depend on what the final most important elements are to you.
Mm-hmm. So let's make it personal. For you, if you picked a healthcare system, which one would you pick for yourself?
3 of the top 4 would be fine with me. The one I wouldn't pick would be Taiwan, mainly because I think it first of all, while there is very high satisfaction in the country with the system, because doctors end up with low pay, they see 60, 90, 100 patients a day. So you don't get time with your doctor. You can forget that. You got a complaint, you want to really delve into it, or you got chronic illness. It's not going to be addressed that way in Taiwan. Similarly, the hospitals there, someone described them with the phrase, they tend to be more like graduate dorms than they are like American hospitals. And families are expected to actually be care providers for their loved ones while in the hospital. very different situation than most countries and most places we're used to. On the other hand, Germany, Netherlands, Norway, I think, and almost any of the countries, I think, have a lot of virtues that would make me want to be treated there. They also all have defects. And again, I can't emphasize enough, it really depends what's most important to you.
Yeah, I was struck by the similarities many of the systems have and what some of the differences are too. But I think just in the context of today, a question I want to ask up front and get out of the way is about COVID-19. And I know you wrote the book before COVID-19 struck. You were able to insert a little coda at the end of it. But the question I want to ask is which healthcare system is best for combating COVID-19? But I guess the real question is that even a healthcare system issue? Is that even a relevant question to healthcare systems?
So let me answer the second part first. It is a relevant question to a limited degree. But I think your intuition, Mark, is of course correct, which is we're in the acute phase of responding to COVID. And in the acute phase, it's really a public health issue, not a healthcare system issue. So it's an issue about preventing infections from spreading and doing what we have now called the public health measures like distancing, physical distancing, hand hygiene, wearing face masks, the non-pharmacological interventions that prevent an infection from spreading. And the healthcare system is more if you have an illness, how do we manage that illness, hospital, doctor, home healthcare agency, etc. That's less of a fundamental part of the response. And the difference between countries that have done well and poor is not about the healthcare system. It's mainly about the public healthcare system. But let me caveat that, as Al Haig would say, with one difference, and that's Taiwan. So by any stretch of the imagination, Taiwan could have been a disaster, a real disaster. It's about 100 miles offshore from China. About 1 million of the citizens of Taiwan actually work in China, and they have scores, if not hundreds of flights, scores, if not hundreds of flights per day with China. Could have been a disaster. Turned out wasn't a disaster. They've had fewer than 500 cases and 7 deaths in the entire island of 24 million people. And that's because of 3 things. One, they're very suspicious of the Chinese. They learned from SARS that new infections there can really be deadly. Take them seriously. Don't poo-poo them. 2, they have a face mask culture, so they wear face masks a lot, and that helped. And we in the West who don't do that are now learning its benefits. But 3, they have this health card, and the health card turned out to be very valuable. The health card, patients swipe it. The Ministry of Health knows why you're going to the doctor, knows what the doctor has done for you, and it's connected to your electronic health record. So the ministry was able to merge the data in the health card with the travel data, the immigration and customs data, to identify patients who'd been to China, who'd been to Wuhan, and who needed to be tested for COVID right away. They were also able to identify people with respiratory symptoms who went to their doctor for coughs or shortness of breath, but were negative for influenza, who also needed to be tested. And this allowed them to identify cases very rapidly, to isolate them, and to do contact tracing so that they were able to really keep a lid on COVID in a way that, Italy, the United States, Great Britain, other countries just haven't. And that health card, with the Ministry of Health able to really use that data very effectively in a public health way, turned out to be a really, really major intervention for them.
And it struck me that of the 11 countries you studied, Taiwan and China struck me as the 2 maybe least developed from a modern medical standpoint overall. But Taiwan seemed to have, of all the 11, the most impressive electronic health capabilities.
Yes.
Is that what you found?
We agree. And I think, it's if we went to a big health insurer, Blue Shield of California or a for-profit United, and we said, all right, we want to identify patients with X who've gone to the doctor and verify that that's why they went to the doctor. It would take them several months, 2 months probably on average, to get us that data through the claims system. Where in Taiwan, it's a day or 2, and much, much different IT system. And you can say, oh, it's only an island of 24 million. Well, they've done something that even other countries of the same size, much richer, Switzerland, Netherlands, Norway, haven't quite been able to succeed at doing.
So some of this is about political leadership and will, I suppose, overall.
Absolutely, absolutely. And
Well,
also trust in government, trust that, the government having this data, fine.
Yeah, yeah, very different here. Well, there were many things in the book that I thought were interesting and some surprising to me, and I thought maybe surprising to some of our viewers.
Probably
Canada.
surprising to me when I learned them.
That's good. Well, actually, I have a question for you about that in a moment. But the first thing I was going to talk about was Canada, which is often held up as a model that we may want to follow in the United States. That's fine. It's a fairly popular health system within the country of itself. It's lauded for having single payer, universal care, and so forth. A couple things surprised me though is you think in this country of universal care, of single payer care, it's not exactly single payer. And the Canadians who have the third highest drug spend in the world, the National Health Insurance Scheme doesn't cover drugs. So what's that about? How do Canadians actually get the coverage and how to get the drugs paid for?
That was surprising to us too, which is, they've had this health insurance scheme for 30 plus years. And first of all, it's not a national scheme, right? What's national, there are 5 principles, and the federal government gives money out to the provinces, but the provinces run it, and the package of benefits varies province to province. And so what you get in Ontario may not be what you get in Alberta or British Columbia. And that was surprising also. It's kind of more like Medicaid in the United States than it is like Medicare in that regard. And then we were surprised that, in fact, drugs were not part of the bargain way back when they passed the Canada Health Act in 1984, and haven't become part of the bargain for a whole variety of political reasons. They do have relatively high drug prices, you are right. And part of and so as a consequence, some provinces have covered drugs. Mostly Canadians get it by their employers buying or providing this as a supplemental benefit to people, or individuals buy a supplemental drug program. But we actually downrated them on the comprehensiveness of benefits, because in 2020, you really expect a country to provide drug coverage. They've come close, but never been able to pass the bill to get that coverage. And I think that's it's a fascinating defect, as it were, of the system, and one I didn't know before I undertook this study.
So they go through employees get it through their employer. What about retired people, for example, who use a lot of drugs?
Yes, you have gaps in care, as they say.
Yeah. So that's one place that, in fact, the government, the U.S. government, with the Medicare drug benefit, may actually have superior coverage to Canada. That was a surprise to me.
Correct.
In some ways. Yeah.
So I think, if you think about the ACA and the 10 benefits that the ACA requires, the usual, hospital care, ambulatory care, we have mental health and substance abuse care, we have auditory and visual care for kids and stuff. The benefit package we have is pretty comparable to the world, actually. And we did not downgrade the United States on the comprehensiveness of the benefit, given the ACA background. And I think that actually is one of the positives we were able to achieve in the ACA, is this uniform benefits package that is, it's comparable to everything in the world.
Well, another system that's often discussed in the United States is the UK. As being something very different, right? It has a nationalized system. It's universal. It's effective. It's very popular within the country. It's got broad benefits. And the biggest concerns we hear about, at least from the U.S. standpoint, is you have to wait a long time and they're short-staffed. And most Americans point to that and say, I'd never want that system with all those things. But it's a very interesting point that the UK spends about $4,000 per person on healthcare. The U.S. spends more than $11,000. So let's say if you were the prime minister of the UK and you say, I'm going to increase our spending, $1,500 a person, almost 50%, which would still be at half the level of the US. you'd probably be able to eliminate those wait times and the staffing shortages, and you'd be spending half of what the US is spending. Does that mean that the Brits are kind of getting a much better value than we are?
They certainly do think they're getting a better value. There are, as you point out, there are problems, but there are also advantages. You know, you don't pay anything at the point of care. That's a huge advantage, right? The deductibles and copays that Americans are becoming acutely sensitive to and really rebelling against, not in the British system.
Mhm.
And I think that goes a lot. People do appreciate that for a lot. On drugs, it is technically the case that people are supposed to have a small copay for drugs. It turns out that 89% of all prescriptions, there's no copay. The government somehow, you fall into some of these subsidized boxes. Almost everyone falls into a subsidized box when it comes to the drugs because of age, income, or chronic illness or other things. They also end up, because of NICE, their National Institute for Clinical and Health Effectiveness, they actually have relatively low drug prices, and drug prices are very closely related to the health benefit. So there are a lot of positives. There is the wait time thing, which is something people bemoan. There's also the quote unquote cleanliness of the hospital that people bemoan. But as you point out, it's extremely popular in Britain. And the other thing we learned is that Britain was probably the first truly universal healthcare coverage in the world right after the war, when they passed the National Health Service. No one else covered the whole population, and the Brits were the first.
I think what the example brought home for me was that we talk about comparing healthcare systems, but one issue is simply the funding. You know, if America said we're going to fund at the same level of Britain, we're going to cut our funding by 60%, we'd probably be pretty unhappy with our system, but the problem wouldn't be the system, would be the funding. So that's an independent variable in some ways, right?
I
Yeah.
totally agree. And, we're, call it 5.5% of GDP higher than the
Mhm.
next highest country. 5.5% of GDP, which means we're spending more than $1 trillion, given our population GDP, more than the next highest country. If we took that out of healthcare, just imagine what we could do with that in other sectors of society, right? As an investment in education, we can make almost all colleges free. As an investment in infrastructure, you could have bridges and roads without potholes. There's a lot of stuff that we forego in the United States because we're spending so much on healthcare that we could allocate to other things that would dramatically increase the quality of life. You could have parental leave, paid parental leave for many months.
Yeah.
There are many, many things that $1 trillion of good we could get in this society. And that's the way I think about the tragedy of the fact that the United States healthcare system is so expensive.
Yeah, even better public health, which we could have used in the past here.
Totally.
You brought up drugs a couple of times. We mentioned that you said the UK does pretty well in drugs. Canada does have like I said, the third highest drug cost in the country, but people in America still think drugs in Canada are pretty cheap. Why are drugs so much cheaper everywhere else in the world besides America?
Well, so in the United States, we have about just under 4.5% of the world's population. We're 330 million. The world is 7.8 billion people. On the other hand, we spend over 40% of the entire world's drug spend, one country. So we are way disproportionate to every other country. When you do this survey, you realize that every country regulates drug prices. Even such quote unquote free market bastions as Switzerland regulates drug prices. We went through and identified 8 different things that these countries do that we could learn from in terms of regulating drug prices. I'm not going to go through all 8, but let me just highlight a few of them for you. First, almost every country relates the drug price to the health benefit produced by the drug. So, if you're saving lives, the price of the drug can be higher. If you're just adding a few weeks to life, you're not actually saving anyone's life with a cancer drug, price has got to be lower. And I think that is an intuitive principle that most people ironically support. We don't have it in the United States. We let drug companies set the price. Other countries regulate it. Almost all of them use objective data. I've just mentioned, the health benefit as an objective measure. A lot of countries like Norway look at what other countries are charging and peg their price to the lowest 3 countries in a basket of comparable countries. They often have automatic decreases in prices. So, for example, you get a novel drug, you get to charge for that drug. But if a second in that what's called class comes in, your drug price goes down. And after a certain period of time, sometimes you get onto a different drug list, and the price really drops 16 or sometimes 50%. So different places have used different mechanisms, but all of them cap the drug price and say, this is the limit, you can't sell it for more. And we identified places that really did a good job. Norway's one, Australia's another, that we think really they knew how to run good regimes.
So there's a couple different ways to do it, but what they all have in common is the government does step in and regulate drug prices, and we don't.
Right.
It's a fairly simple answer.
Typically, after a drug is approved that it's safe and effective, then there's a second process that looks at what the legitimate or price maximum is the typical way it's done. And, that is, they have a formal process. In Germany, it can take no more than 12 months, very specific timeline. During that 12 months, drug companies can charge whatever they want, but after that 12 months, it's regulated.
So that's really the political will and desire to regulate.
Absolutely.
Overall. We've gotten a couple questions about mental health care. And I know that one of the things you found that all of the systems you studied had in common was no one's really found a sustainable and efficient way to address mental health care. The US and a few countries actually have done a bit better than the rest, but still no one's really solved that problem. And it's curious because for years we've known that there's a big burden of mental illness from a health standpoint. We know there's a lot of cost spillover to the physical health that we spend a lot of money on. So why do you think no country's been able to solve this, and who has at least done the best at it, and how?
Mark, you say we've known for a long time these relationships between mental health and physical health and mental health and high cost. I don't think it's sunk in. So, the typical response, and I think you're 100% right. We specifically wanted to look at mental health because we thought it was so important. And by the way, because it was going to be of growing importance, and this was before COVID. And I think it's undeniable that it's going to be a major focus for decades to come. So it was a major focus of our study. And the way in which it's been dealt with was best characterized when we went to Geneva, Switzerland, and we talked to the head of the canton's health system, and he said, "Oh, mental health, yes. We have a mental health hospital. It's over there." And he points, and he says, "It's on the border with France, right near the prison." And that summarized everything you need to know about the traditional approach to mental health, which is isolate it, put it as far away as it can, make it socially filled with opprobrium right near the prison. Only recently have places begun to realize what you just said. This is, it's not voodoo, it's serious problem that has a physical correlate in the brain, and we need to treat it like every other illness. Second, it's very expensive. It's expensive for the mental health problems, whether they're substance abuse or serious schizophrenia, but it's also expensive because people with depression or anxiety who have other illnesses, say cancer or diabetes or heart disease, they're harder to manage if they have those chronic illnesses and mental health conditions. So if you address the mental health conditions, it turns out their expenditures actually come down on the physical health side of the range. Well, places are taking a look. We identified both the Netherlands and the United States as the two best in this regard, mostly because they're trying innovative things. So in the Netherlands, the government basically said, primary care doctors, you're the first line of defense for common, not mild mental health issues. Things like depression, anxiety, situational depression. If you really have manic depressive disorder, then it's a time for a specialist. The primary care doctors have, more than 80% of them have hired nurses who are specifically focused on the mental health of the patients. And they have seen appointments for mental health issues at primary care go up twofold, so that they really are getting people to come in for mental health issues, addressing them with this nurse specialist. And it seemed to be a novel and useful approach. It's a kind of approach that we've called that the experts in the United States call the collaborative care model, which is you co-locate a mental health expert with a physician practice, either with primary care doctors or specialists. And that relationship turns out to be, or we suspected was important. We've obviously seen online mental health explode during COVID, but it was there before. Progressive places like Kaiser or Advocate Aurora in Illinois had online support for mental health because some people don't want to go in. Some people are having an emergency crisis, can't come in, and you need to work with them virtually. We thought the United States was trying a lot of novel things, and there was a lot of progress in that area. Again, not solved, and it hasn't been disseminated system-wide or scaled, as we say. But we thought that we were doing more than many other countries in this space. And, you know, I'm actually a believer that if we keep working at it over the next decade, we will literally be able to solve this problem in the United States.
Well, let's hope so. It was notable when I read your book and looked at, well, what do all 11 countries have in common? And one would think, good or bad, you know, that says something about the difficulty of changing it if no one's been able to solve it. And another commonality in that vein was, seems like every country has been stymied in eliminating wasteful or low value care, which we know not only wastes money, but often is harmful. It's actually worse getting treated if you don't need something than not getting treated at all. And also, a lot of the plans for improving U.S. healthcare and reducing costs are saying, well, let's get the waste out. We can all agree on that at least. But if we haven't been able to do it here and no other country's been able to do it, that's daunting. So why do you think it's been so hard to eliminate or reduce low value care?
I think, first of all, I think doctors everywhere have a hard time identifying low value care and have a hard time having the incentive to get rid of it for assorted reasons built into their systems. And, you know, just to give you an example, in Germany, well, in most of the developed countries, not all of them, the number of hospitalizations has gone down. People are using hospitals less and less. They've been able to handle a lot more procedures, whether it's cancer chemotherapy or some surgical procedures, out of hospital. And so we've had fewer hospitalizations. And as a consequence, handling more of the care outside. Germany hasn't been that advanced in getting rid of hospital beds. They have 40% more hospital beds on a per capita basis than the United States. One consequence is you got empty beds, you use empty beds. And we know this supply-induced demand. So they think they have a lot of unnecessary surgical procedures happening, a lot of hospital admissions that don't require hospitalization. And that's a lot of waste and a lot of expense. But for a lot of political reasons internal to Germany, the local community doesn't want to get rid of the hospital. They fund the capital expenditure, so they're not closing the hospital, even though the national government thinks those hospitals ought to close. So these dynamics of who funds what part, how these decisions are made, they tend to be unique in every country, but they all often come to this issue of, well, you know, there's a more efficient way of doing it, but we're not doing it. So, you know, in Norway, the federal government pays for the hospital, the municipalities pay primary care. Given that circumstance, the municipalities are, you discharge patients and we have to take care of them on the outpatient basis. It's going to be more expensive for us, and the savings doesn't go to us, it goes to you. So it creates some conflicts in systems. We saw that very frequently. This sort of, the financial incentives are not aligned to be more efficient.
And there's a lot of economic inertia in all these countries that makes it really hard to disrupt the system.
Yeah. Well, you know, a lot of these healthcare systems were, the foundations were built in the 50s and 60s. And at that time, acute care, you know, whether accidents or, you know, acute myocardial infarction, those were the focus of how you built the system. And those were done at the hospital. Now, for the 21st century, we realize it's not acute care, it's chronic care. That's the real big problem. 85 cents of every dollar in the United States is spent on chronic care, and the hospital's not the best place to deliver chronic care. And all of them are trying to transition away, but they've got these legacy systems that create a lot of inefficiency in how we deliver optimal care.
Yeah, and big fixed assets as well. Well, we're getting a lot of questions about payment systems and single payer and so forth. And something that struck me when I read your book was, there's so much of a dichotomy in people's minds between single payer and a private system. And you you defined 5 different systems across that spectrum. And what I had never thought about before is you pointed out that the United States has all 5 of those systems somewhere in America. You also point out, it's very interesting because you took a historical perspective for each of these countries. Where did their healthcare system come from? Sometimes going back a few hundred years. And of course, that's the delivery system and the financing system. And you made the point that there are examples of systems that were government focused that have expanded the use of private insurance. But you couldn't find examples of systems that were primarily private that moved to a single payer. So
Yep.
all that said, what does it mean for the US? And I guess that maybe the backing up question, if I back up a little bit, is how important is it what kind of a payment system we have versus the notion of getting everybody covered? We don't want to confuse single payer with a universal coverage. So what did you take away from your research on that?
You really read the book. That's what I take
Oh,
away.
I read it.
You read every page. So one of the things I would say is when you look at these countries, they have all different ways of getting to universal coverage. There's not one way. You can do it a lot of different ways. So Britain is the classic socialized system. The government basically owns the delivery system and pays for it. We have that in the United States. It's called the VA. And by the way, the vets are very happy. So that's how we have. Then there's a system where the government is a single payer. It pays the bills to doctors and hospitals. People get coverage. We have that in Medicare. That's Part A and B. That kind of system, you have that in Norway. You have that in Canada. And that is, and it's relatively small part for private insurance. In most countries, it can be tiny or not at all. But we have that in Medicare, where we have a small part of private insurance called Medigap. And then there's a system where the government pays, but there's still a big place for private insurance to supplement the government. France is the leading case. They have a statutory state-based system, but it's very thin in terms of their high co-pays, and so 95% of the population has supplemental insurance to end up solving that problem. And then there's the Netherlands and Germany, where the payment goes to the government. You choose a private insurer. They call it sickness fund. And then the government pays the premium to the sickness fund. And you pay a little premium. The deductibles and co-pays tend to be very small and modest. That's like our exchanges, like Medicare Advantage. And then there's a completely private insurance system that's like Switzerland, and we have that too. The fact that we have all of these is highly inefficient, creates a lot of conflict, and people complain about our administrative costs. That's why we have high administrative costs. All this complexity is a real problem. And so one of the things I call for in the book, or think that we could do, is you can get to universal coverage using any one of these systems. But we need to simplify what we do. We can't have 5 different competing ways of paying for healthcare out there. We've got to get down to, I suggest 2 would be the best mechanism. And I do think we're not going to get to universal coverage unless we do that. And so I worry less, is it private insurance or single payer, or the socialized medicine arrangement. We need to I think we're stuck with private insurance for the reason you mentioned. We never saw a country that had private insurance went backwards. And the main reason is, first of all, the insurance companies become an interest group and they resist being put out of business. And second of all, the American public has clearly a very contradictory, conflicted, complicated relationship with insurance companies. There's no better political applause line than bashing the insurance companies. On the other hand, we've seen from polling tell the American public we're taking away your private insurance company. Oh, no. You can't do that. So my suggestion is let's make peace with that and create an exchange where, like Germany and the Netherlands, you can choose your private insurance company. The government will pay most of the premium. And I think that could just be a much more efficient system if we put 150 or 200 million people in that system. You can keep your employer-sponsored coverage, or you can have this system, and that's it.
That can be simpler. And certainly we've proven through the Affordable Care Act, we are able to meaningfully decrease the number of people who are uninsured. So we can extend that.
We could if we simplified the system a lot. I mean, look, I can go on and on about all the defects we put into the Affordable Care Act, but one of them that I think turns out to be much more complicated is to determine your eligibility for the exchanges. You look at last year's income. Determine eligibility for Medicaid, you look at last month's income. Why do you have two different standards? This makes no sense, especially because we know those people, their income fluctuates. So we should have one standard, the Medicaid standard, and it should apply throughout.
Well, I've got a number more questions about the world's healthcare systems, but I can't keep down some of the questions coming from the audience just about COVID-19, since you've been so outspoken on that too. So I'll just pick two of the key ones are, we're not so good consistently at wearing masks outdoors, in case you hadn't noticed. So is there any hope on flattening the curve if we don't enforce an outdoor mask policy? And then the second one too, the second question about COVID is just about the vaccine. How confident are you that we'll have something by the end of the year? And whenever we have it, how long do you think it will really take to roll out to most of the public?
Well, I do think there was 2 days ago, I think, in the Washington Post, this very revealing graph where they looked at Europe and they looked at the United States in terms of cases. And in Europe, it went up and down, and the United States was a week or two behind Europe in terms of the case rise. We've gone up, come down a little bit, and then plateaued. And what is that difference? That difference is the stringency and rigor with which the public health measures, not just face masks, but all of them together, have put into place and kept there. We have never uniformly put them in place across the country. We've had different locales balk at it. Now they're having big outbreaks. So we've not put in physical distancing, reducing crowds, hand hygiene, consistent wearing face masks, closing non-essential businesses. We did that rigorously nationwide for a short period of time. You would have been able to get the caseload down so that testing and contact tracing and isolation would have been doable. Europe has beat us, and our inability to do that rigorously has been, it seems to me, the Achilles heel of our fight against COVID-19. I do think face masks are an essential element. Early on, I made a mistake and was listening to the CDC. I'll learn never to do that again. Listen to the CDC about face masks, and they were giving the wrong information. And then I did research, looking. We've actually had plenty of research before COVID about the value of face masks, not so much in COVID because we didn't have COVID, but in flu and in droplets, and they work. They're not, cloth masks aren't as good as surgical masks and aren't as good as N95, but they're not ineffective. And if you wear a cloth mask and actually put a nylon stocking over, they're really effective. And before the CDC, changed their mind, I was out there in the public on the TV show I hosted on MSNBC. Got to wear face masks all the time outdoors. You got to wear a face mask. You don't know if you're asymptomatic and transmitting. You don't know if someone's around you transmitting. And that would be really, really important. And I think we've got to establish that as the norm. We've had difficulty establishing it as the norm with a, president, frankly, who flaunts it, who has, press conferences in the Rose Garden, and every one of his aides, his son-in-law, all of those people aren't wearing them and are modeling bad behavior. So I just think it's going to be hard for us to get the number of cases down, really get our arms around this illness, unless we actually do these non-pharmacological interventions seriously.
And what about the vaccine question?
So We're about to start phase 3 trials of the vaccine beginning in July. You've got to enroll 30,000 people, 20,000 getting a vaccine, 10,000 placebos or some other vaccine. Then they have to be exposed to the virus and see if they come down with actually COVID-19. That's going to take time. Do I think we'll be able to get there? I think the answer is probably yes, probably by the end of the year, early next year. But I think that there are two big issues that we have really not addressed that are lurking out there. We're so hungry to get a vaccine. One is, what's the durability going to be of any vaccine? How long is it going to last? One of the problems we know is, there are 4 COVID viruses that we get colds from, and you get antibodies to them. But those antibodies don't last. They last between 3 months and 12 months, and then they disappear, and you can get the same COVID vaccine, COVID viral infection. That's a problem. That would mean that we'd have to be re-immunized all the time, and you'd have to do the whole population. We don't do so good in immunizations for adults. We do better for children, but not better for adults. And 45% of the population gets a flu vaccine. That's a big challenge. And if the virus, our immunity to the virus goes down, that's going to be a big problem. If it is less than a year, it's going to be a disaster. The second big challenge, again, that I don't think we're addressing sufficiently is how are we going to distribute the vaccine to get to 220, 240 million Americans to create herd immunity. The traditional way of going to the doctor's office, going to CVS, I don't think is going to get you there very fast. Certainly not within a relatively short period of time. And I don't think we're thinking about that distribution. And one step before that distribution, you have to take a vaccine, put it into a sterile vial, ship the vial out. That putting it into the sterile vial sounds simple, right? Simple. That's called fill and finish. That fill and finish function turns out to be very complicated. Though factories in which manufacturing facilities in which they do that fill and finish are 100 times more sterile than operating rooms in hospitals. 100 times. They take years to build. And the world's capacity of fill and finish is actually quite constrained for vaccines. We actually should be building a couple or 3 more of those production facilities, and yet we're not. And I think that's going to turn out to be maybe the rate limiting step here. So I really worry about even if we get a vaccine, when are you and I, non-frontline healthcare workers, going to get it? And I would think that's not going to be before Q3, Q4 of 2021.
That's a ways. And of course, you're only talking about the couple 100 million Americans. There's 7+ billion people in the world overall. Exactly. And there's no guarantee that the vaccine will first be released in the US, right? So we
no, there isn't. The Chinese, I literally just before I got on the show, got a call. The Chinese are doing their studies, and some of it looks good. Well, they have 1.4 billion people to get the vaccine to.
Yeah, it'll be quite a challenge. Let's get back to some of the comparisons with the U.S. and the rest of the world. We do have some of the same problems as others, but as you pointed out, we also have some of our own, or at least we're an outlier. And the most obvious one is cost. You mentioned we spend a lot more than other countries as a percent of GDP. We're just under 18%, I think, what I saw most recently. And Switzerland is the second most expensive country, just over 12%. That's a huge difference. And notably, those 2 countries, the 2 most expensive in the world, rely on private health insurance more than most others do. And neither country has a budget for healthcare to say we're not going to spend more than X. So it's just, that may be more than a coincidence. Does it imply that the only way to contain costs is to have the government as payer, or to have a total budget, or both?
I do think that a total budget, we're not exceeding this. And by the way, if you guys exceed this, we're just going to ratchet down what we're going to pay you per unit of office visits, of surgical procedures, is something other countries do. And they are able to keep control of the costs. Stu Altman, who is one of the great health policy geniuses, he's been around for 20 plus years, 50 plus years now. He's sort of the dean of health policy experts. He says, you know why Europe pays less? Because they pay less,
Yeah.
because they got a budget and they stick to the budget. And so you see in other countries, Taiwan is a good example. Germany is a good example. You're spending more, you're seeing more patients, you're providing more services. That's fine. But instead of getting, 100 cents on the dollar, you'll get 90 cents on the dollar if you have 10% more higher frequency of visits. You cannot game this system by just increasing your volume of care. We do not have that kind of control. And I think, we didn't do a comprehensive study of it. It's anecdotal or informal. The countries without a rigorous budget, who have a large segment of uncontrolled private insurance, they have higher spending. Now, both the Netherlands and Germany, they have private insurance, but they have a budget and they keep the private insurance under the budget. And I think that is a very effective technique that we need to think about in our country.
And without going too deep into it, because you weren't focusing on states, but both Massachusetts and Maryland in our country have some sort of a budget or a target, and they seem to be two of the more successful states in reeling in their spending. Is that correct?
Yeah, it's not just them. You're now seeing it in Rhode Island, Connecticut. Yes, I think people have cottoned on to this idea that we need to have a target. My favorite target is flat.
Mhm.
No real increase in healthcare spending. We're going to 18%. That's the limit. We're not going above 18%. You guys figure it out. There's more than enough money there. You can't say that there's not enough money once we're spending 18% of GDP on healthcare. You guys reorganize this. And I think that actually would be a very effective idea.
Well, speaking of, you have a whole budget. You also have different components. So I've got a question I'm going to combine with one of the audience questions, because one of the things I noticed is that physician salaries vary tremendously from country to country and not related necessarily to the income of those countries. I just looked this up. In Norway, the U.S. average income is about 142% higher than the average income in, I'm sorry, it's 29% higher, but our income is, but our doctors are paid 142% more. Norway general practitioners average about $92,000 a year in salary, and in the U.S., the average primary care doctor gets about $223,000. So there's not a correlation there, and it's hard to imagine that U.S. doctors are that much better. So that's one key piece of the costs. We've also been talking about drug costs. Drug costs are about 17% of our total spending. If all of the drug companies decided to be generous and give us all the drugs for free, we'd cut 17% of our costs. And we would still be by far the most expensive healthcare system in the world, right? So what are the other drivers of costs? Maybe doctors are one piece of that, but what's driving the other costs besides the 1/6 that's drug costs?
Well, drug costs are the biggest component. The excess drug costs that the United States spend is the single largest component of the difference between us and these other countries. Hospital prices have become not hospital prices for Medicare and Medicaid, but hospital prices for private insurance in particular have become a major cost driver of the United States healthcare system. Way back when, 2 decades ago, the price difference between Medicare and private insurance for a hospital day was minimal, 6% or something. And now it's over 100% difference. And so that's because hospitals have consolidated. They've got local monopolies or near monopolies, and they can dictate prices. That has to be regulated. The fragmented way we have insurance companies negotiate we might bemoan insurance companies, but it's undermined their leverage vis-a-vis hospitals, while we've allowed hospitals to consolidate and create these local monopolies that increase their bargaining power with the private insurers. So hospital price is another area. Then you look at things like MRI scanners, CT scanners, big ticket items. We have very high prices for those compared to the rest of the world. And we have a lot of machines. We're second highest per capita in terms of machines. So we've got high machines, high costs per test. And that tends to drive up a lot of the pricing. So, it's multifactorial, high prices for things that are used a lot, where we've created a situation where there's not any particular body that can keep the price down. It is a major problem. So that leads to the natural point, which is, payment reform is going to be essential for keeping prices down, and delivery system reform. We've done some of that. We've done a lot of it in the United States. We are innovative compared to the rest of the world in that regard. I think over the last few years, it's run out of a little steam. It needs a recharge. And hopefully the next administration will really focus on that and really push, not just for government programs, but also for the private sector to have these alternative payment models fully rolled out.
So a few things I take away from all this is it seems that, at least from your analysis, that regulation has worked better than private sector competition so far in keeping prices down. The US is one of the most, if not the most innovative healthcare system. And that actually has allowed us access to innovative drugs and things maybe at a better rate. But also, unlike in many other industries, innovation has not succeeded in keeping prices down either, or costs down either. And the
Yes.
third thing I mentioned, price versus cost. We know we spend a lot. We haven't talked specifically about this, but it really seems like more than Americans having a problem with using too much healthcare, the main reason we're more expensive is simply our prices are higher for drugs, hospitals, and doctors. Yeah.
Right. Well, when you do look across countries, it tends to be prices. Within the United States, a lot of it tends to be volume and practice patterns. And so it depends on what you're looking at. Look, I'm a big believer, it's both. You got to get prices down, and there are plenty of places where we've got either too much volume or the wrong kind of volume. And you need to decrease or shift from, say, inpatient surgical procedures to ambulatory care procedures, which are, same procedure, just done more efficiently and cheaply. Or you need to switch from radiation therapy that goes 7 weeks to radiation therapy that's equally clinically beneficial and is only 3 weeks and therefore cheaper. So I think there are a lot of these efficiency gains we could have, as well as trying to get rid of more unnecessary care, and use more tertiary prevention to prevent us from even needing care.
One of the issues you looked at across all 11 countries, which is sort of on the fringes of the major medical system we have, is long-term care. And I was interested, you found that of the 11 countries, 2 of them in the study, the Netherlands and Germany, have dedicated funding mechanisms for long-term care. So that means there's a way to fund it. My question for you is long-term care therefore more affordable in those countries? And is there evidence that people who need long-term care are more likely to get it because of those funding mechanisms?
So that is a very good question. When I went to Norway, and at least progressive things, everything Scandinavian's got to be better. It turned out, well, long-term care was not better. It really looked a lot like the United States. They were getting by with baling wire, chewing gum, and it wasn't a stable system. And they knew it wasn't a stable system, but they couldn't actually figure it out. And part of it is there's no dedicated funding stream. And so as a consequence, elderly people and their families actually pay a substantial portion of the care out of pocket. And this turned out to be, kind of surprising. Usually you think, Scandinavian countries, the government's taking up almost everything, right? Education is free, healthcare is, pretty low, if not free, but not long-term care. The 2 exceptions were Germany and the Netherlands, which have this private delivery system. They use private insurance companies, but they tack onto the tax that they get a dedicated tax for long-term care. So at least on the financing system side of it, unlike all the other countries that we looked at, they have a system for actually paying for it. We were particularly interested in the long-term care because of the, every country is aging, and the sort of what's called the silver tsunami is coming. Almost all the countries were trying the same approach, which is what's called aging in place, trying to keep older people in their own houses or in their relatives' houses, not move them into institutional care, because institutional care is very expensive, but and tends to be for very frail people, people who have multiple chronic illnesses, incontinence, really advanced Alzheimer's. Otherwise, countries were actually trying to keep them in their own apartment. And I will tell you, one of the more innovative things we saw was Germany, where you could pay to get that. They paid the family they could bring in a healthcare worker to help care for the elderly person, or even if the family did some of the care, they would get paid for providing some of that custodial care for the seniors. And I thought that was, we have, I think, hundreds of billions of dollars of free care provided by families for elderly people, that you probably don't want to pay for all of it, but recognizing that people are doing this and that it's a social benefit probably is important. And Germany provides a very interesting example of that.
Yeah, and might actually save money if it doesn't increase the total cost by keeping.
If it doesn't begin sending people to institutions, and we've seen how problematic the nursing home business is, and you and I know that a huge portion of the Medicaid spend, not about poor mothers and kids, or young adults who are working retail and don't have health benefits. It goes to nursing homes for elderly,
Right.
and that's not an ideal way of providing long-term care.
One of the criteria that you looked at in terms of evaluating different systems is choice. And in the US, we love choice. We place a premium on patient choice, insurance plans, doctors, hospitals, whatever it is. And we're willing to pay more for that choice. And we do pay more for our whole healthcare system. So my question to you is, did you find that Americans have more choice in healthcare than residents of other countries do?
Absolutely not. We have less choice by and large than many other countries. And I think that might surprise a lot of people. So again, if you were looking at the places with the most choice, you would look at Germany and Switzerland and France. More or less unlimited choice of doctor, no gatekeeping model, so you don't have to go to a primary care doctor to go to a specialist. There are countries like the Netherlands, Norway, where you have more or less unlimited choice of primary care doctor, but there is more of a gatekeeping model when you get to specialists and hospitals. And I think we don't have that. By and large, an employer finds an insurance company for you, and you get that insurance company. You don't have a choice of insurance company. And then the insurance company, typically, they might have a PPO, they have a network. You don't have unlimited choice of doctor. So it turns out that in most other countries, choice is actually better than the United States. And again, I think that was one of the surprising findings for me, and probably will be for most Americans reading the book.
You mentioned, we've talked about a couple places where you were surprised. Any other places where you were particularly surprised by what you found in doing this research?
Yeah, I was surprised by how recent universal healthcare coverage is in many countries. A lot of us in America beat our chest about why are we stuck at 90%? Why can't we get to universal coverage? Why do we have to be the outlier? But it turns out that a lot of countries have been late to the game. Just to give you an example, Switzerland, yes, by 1960, 80% of the population was covered, but to get to true universal coverage, that was 1994. Taiwan, it was 95. France, it was 2000. So it turns out real universal coverage is more recent than many people think. And certainly many people, included me. So, I think that was one of the surprising findings as far as I was concerned.
We'd all like to take the best of what you learned from the other systems and import them to the US, and that's hard to do. What are the main barriers against importing something else from another country into a system in a country like the US?
Well, it's called, the political scientists, the economists call it path dependence. You got institutional structures. It's going to be hard to get rid of those institutional structures or dramatically change them. You can add on to them, but the underlying structure is hard. And I mentioned one of them already. We didn't notice any country that had a big private insurance system that went backwards, or not backwards, went to a universal coverage system and basically got rid of the insurance system. You might want to say Taiwan, but there's a whole series of things where it was a different example. But once you've got a relatively large insurance component, going to a governmental component and getting rid of those insurance companies, not going to happen. And so I think we have to think about those structures and how we adapt to those structures. On the other hand, things like how we pay doctors, those things are evolving, and we did see them change. And I think, conservation of energy, don't beat your head against the wall thinking you're going to get single payer, and figure out how to change the delivery system and change payment to doctors to get them to do more of the right thing is kind of the lessons I learned. One of the other lessons I think that I'm quite passionate about, I'm the son of a pediatrician. We in the United States make families pay for their children and for the private insurance of their children. No other country does that. Every other country, children are seen as an investment, a social good, and society should pay healthcare for them. So even in systems like the Netherlands and Germany that provide coverage through private insurance, it's the government who pays for kids, not the family who pays for kids. I think there's a lot to that, and I think we ought to think about doing that in the United States. Paying for family coverage is about $6,000 direct premium. Obviously, the whole thing is paid for. That's a lot of money for the average household in the United States to pay for their kids. And I think that is, that leads to a lot of inequity in our system. And we still have 4 million kids, by the way, without insurance. And I think that is also just an appalling number.
Yeah. But we do have some promising, we have some programs that partially take care of that have had bipartisan support. So maybe there's an opportunity there. This is a little bit discouraging for an American when we're looking at these different systems. The U.S. falls short on cost. It falls short on universal coverage. It falls short on choice. The quality is inconsistent. You point out in the book, the U.S. ranks poorly in areas that are amenable to intervention, infant mortality, maternal mortality, and so forth. However, somewhat to my surprise, near the end of the book, you write that because of innovation, I'm going to have this exact quote, in the next decade or two, the United States will again become one of the best systems in the world, unquote. What makes you so optimistic?
Just that. We are very innovative, and we're fed up with the system. And I think that combination has the possibility of permitting true reform around payment, around how we're delivering care to really jack us up. Mark, when you and I started in this, more than a decade ago, it was really common throwaway line. The United States has the world's best healthcare system. I don't think anyone who's responsible believes that anymore. And that is a very important change, because you will not do major reform to a system if you think it's really good. You'll do major reform to a system if you think it's really broken. I think it's really broken, and I think the public realizes that, and most people working in the healthcare system bemoan that. Second, given a lot of innovative people, I think we will come up with unique solutions and solutions that work. I think we have innovations on how to pay doctors. We have innovations on how to deliver chronic care management. We have innovations on mental health. I think those need to be scaled. We need to winnow out the best ones of them. But that's what gives me optimism. Being a pessimist, being a skeptic, health policy people are famous for that. Mm-hmm. And I think it's easy to be the skeptic about it because it's hard to change the system. On the other hand, I think people have become fed up with what we've got, and I think that will be the propulsion we need to really change the system. And I think I wouldn't be surprised if the next administration has a big window of opportunity, assuming the Senate flips.
Well, I'm glad you brought that up, because we actually, unfortunately, I have time for just one more question. And here's the one that I had in mind to ask you. I'll ask it. And this is really, how do you think the U.S. healthcare system will change following this year's election? And it's one question, but I want you to give me two answers. One for the status quo, if that holds, and another if the Democrats win both the White House and the Senate. What do you think will happen in U.S. healthcare in those situations?
Well, if we have the status quo, you won't get any reform. Donald Trump has been quite clear, uninterested, actually interested in repealing the ACA. You won't repeal the ACA because the House is, going to stay Democratic. But I don't think you're going to do any innovations, and they're going to try, assorted things like they did in the last 4 years to nibble away at it. change the open enrollment periods, make all sorts of rules like work requirements, do whatever they can to undermine the program. I don't think there's going to be a lot of success with that, frankly, but you're not going to get progress. The flip side is, I think if the Democrats come in, what's the top of the agenda? Some drug price regulation, I think, is going to be the American public going to expect it. Some major reorganization of the payment system, because with 14 states not expanding Medicaid, you have no path to universal coverage. You have to do something different about that if you're actually going to get to universal coverage. And I think that opens up possibilities for more extensive reforms. You might even get hospital price regulation. So I think there are a lot of possibilities to think creatively if the Democrats do get in. I think they also learned their lesson. Negotiating, trying to make it a bipartisan bill with the Republicans, probably of no use. And so I don't think they'll waste that much time with that. And I think they'll focus in on what is likely to be the biggest bang for the buck.
Well, we'll have to have you back at that point and see what things are looking like then. I want to make a big, give you a big thanks, Zeke, for joining us, and a thanks
Thank
to
you for a great
Dr.
interview.
I'll do this formally. Thanks to Dr. Ezekiel Emanuel, the author of Which Country Has the World's Best Healthcare? And we encourage all of our viewers to order your copy today through your local independent bookstore. We also want to express appreciation to all of our viewers. Thank you for coming, and thanks for your wonderful questions. I'm sorry I couldn't get to all of them. Commonwealth Club has a wide range of virtual programs, both about healthcare and many other topics, so please visit our website for more information. I'm Mark Zitter, and now this virtual program of the Commonwealth Club is adjourned.
Thank you.